So we want to talk a little bit about managing, pelvic vein disease, and just basically when we talk about this, I want you guys to think about every single aspect of disease that can originate from the pelvis, whether it affects the pelvis, whether it affects the legs, or both when we're talking about it. But more importantly, I don't want this to be, a lecture per se. I really want to highlight more the impediments that we feel exist to either patients understanding that they have the disease, doctors who see these patients, not us, but other physicians, when they complain about symptoms that may be related to pain disease, to pelvic disease, and then also the people who practice managing vein disease itself, who may not be as aware of pelvic, vein problems. So impediments both with patients, referring physicians, and also people treating the disease itself. And we'll touch a little bit obviously upon how you may treat the disease, but more importantly, the main thing is, to me, it seems that it's a hard wall, so to speak, to overcome. Getting it out there in the public's knowledge and also in referring physicians' knowledge. Have any of you had the experience? Let's start with the referring physicians, because they see these people coming with relatively what they think nebulous complaints, and they don't kind of put two and two together to think maybe there's something going on.
Again, the context is, which patients are you talking about? The patients who have the lower extremity varicose veins, who end up having pelvic origin varicose veins, are coming from a large group of physicians or self-referred, probably not recognizing that they were pelvic origin in the first place. And a large number of them are women who've had a number of children and are coming to us from the gynecologists. And so that particular pathway follows, for the most part, the same referral pattern as our lower extremity varicose veins do in general, with perhaps some more enlightened physicians who are recognizing pelvic origin veins and referring them. It's a completely different referral pathway for the patients who come with chronic pelvic pain. And there we're not seeing the same broad spectrum of physicians who refer. Most of the time, those are coming from physicians who we've had contact with and have discussed the issue with them. And so in our local area, it's a lot of the chronic pain physicians, usually physiatrists in our hospital, and outside our hospital, pelvic pain specialists who have a large presence in the New York City area. And so increasingly, we're seeing referrals from those specific types of physicians for the chronic pelvic pain patients.
Mark, how about out by you, Mark? Where are your pelvic pain patients coming from in terms of physician pain, not other self-referrals and stuff, but where do you guys see the most type of physicians sending patients?
To be honest with you, almost all of my patients are self-referred, and we have and it's probably not optimal. I wish we got more from gynecologists, but I would say 80% of my patients are self-referred.
And what's been your dealings with? Do you think the gynecologists are the ones that harbor the most of these types of patients, or as Neil said, these chronic pain physiatrists or pain physicians that are taking care of these people?
I think it's both. I think, if anything, for a lot of these patients, the chronic pain physicians are probably underutilized for it and ought to be more involved in it, because I do think this is there are multiple pathways that lead to chronic pelvic pain, and while pelvic varicosities may be the starting point, ultimately a lot of this is a chronic pain problem that the pain doctors need to be involved with that.
Yeah, there's some interesting literature that shows these patients, particularly the ones who don't get diagnosed for quite some time, enter and leave healthcare engagements very over a long period of time. In other words, they go and see a doctor, they start a workup, it doesn't go anywhere, it doesn't solve their problem, they disengage from healthcare, they come back, they go to a different doctor, sometime in a different specialty, and engage with them, sometimes don't get relief for their problem, sometimes are told there's nothing wrong with them, they disengage, and a lot of times they live with this pain for a long time. So, you know, probably many of these patients are seen by a number of different types of physicians. I imagine most of them at some point are seen by at least one gynecologist along the way. And so that's probably where most of the chronic pelvic pain patients get their primary attention, but ultimately they start to see a number of physicians in a lot of different specialties.
Yeah. Tony, what's been your experience with the people that do refer and those where you're having trouble making inroads in educating the physicians?
Yeah, my experience is the same as Mark. I mean, I would say probably 90, if not higher, % of the patients are self-referred. I've tried to do what Meredith was telling earlier about reaching out to GYNs and going and giving a little lunch and learn. But it's very difficult. I think there's the question here is, you know, getting into the education of them during medical school or even during the residency to understand the role of pelvic venous insufficiency or pelvic disease in the development of pelvic pain. And unless they get that, and it's not part of the differential, they're not going to believe in it, and they're not going to send the treatment. And then the other question is, you know, the alternative to embolization, surgical, and that's something that they can deal with. And maybe there's a few patients that end up down that route versus referring. But I agree with Neil. I mean, majority of these patients, I'm sure, at some point have exposure, you know, unless they're having GI symptoms or something completely different, have exposure or have been seen at least once by a gynecologist. So if we can somehow tap into that specialty, I think a lot of these patients will come to us.
No, and I think Tony's right, and I think it's a little bit of a two-way street. I think there is a lot that vascular specialists or vein specialists don't understand about chronic pelvic pain, and there's lots of things that the gynecologists don't understand about venous disease. And, you know, we've done, ultimately, although we can do this one-on-one with each individual gynecologist, I think overall the best long-term plan is to increase the dialogue both ways. And I think we've started to do that a little bit in some of the pelvic projects we've been working on, and it's been very well received by both the American College of Gynecologists and Obstetricians as well as by the International Society for Pelvic Pain. We have been very willing to engage in this, and I think it's a learning thing in both ways. I think I've learned a lot from them about chronic pelvic pain and vice versa, and I think in the long run that's probably the best solution to this all, in that engaging individual gynecologists probably may be successful for our individual practice, but for patient care in a broad sense, it really involves engaging the entire gynecologic community on a scientific basis, I think.
Into something that Mark said. Mark, what did you learn? In other words, let's go the opposite way. What can we as vascular specialists learn from the OBGYN people? You said that it's been a learning experience in both directions. What were the things that you learned about pelvic pain, and what can we as vascular specialists need to be aware of when we're seeing these people? What did they teach you as you've had these dialogues?
Well, I think that a lot of chronic pelvic pain is multifactorial, and you know, women may have ovarian vein reflux or common iliac vein compression and have pelvic varicosities. But I think if you've taken care of enough patients, you realize the most patients you don't completely cure of their pelvic pain. You may make them much better, but there are some other things going on that need to be addressed as well. And really, I think like a multidisciplinary approach is really what's needed for a lot of these women. It involves a gynecologist, involves a vein specialist, and involves a pain physician. You know, there's some pretty robust data from the neurofunctional imaging of women with chronic pelvic pain that, you really do get some cerebral changes. When you have long-standing chronic pelvic pain, you get a decrease in periaqueductal grade matter, a decrease in pain processing pathways, and some other things. And all of that has to be addressed. And I think that's what I've learned a lot from our GYN colleagues who specialize in pelvic pain. And even though they recognize pelvic venous disease as one of the causes of it, that in many cases there are other dimensions to be considered besides just the pelvic varices.
Yeah, so there are OBGYN guys who basically they're pelvic pain specialists, so to speak.
Yeah, one of the things that maybe not so apparent to us, but perhaps should be, is that just like there are vein specialists and there are true venous specialists, there are gynecologists who do general gynecology who don't really deal with patients with chronic pelvic pain, and so they're not comfortable, not as experienced as doing the appropriate workup. And now we're talking about specifically, again, patients with chronic pelvic pain only. This is just a subset of the pelvic venous disorder patients, but they're just not so comfortable doing that workup themselves. They rely more on imaging and laparoscopy than they do on physical exam and history taking. The gynecologists who Mark and I have worked with on our committees are the first to recognize the fact that there isn't really a robust training pathway for physicians who are interested in chronic pelvic pain, and consequently, there are not very many residency programs that stress the evaluation of these kind of patients, and there aren't that many skilled people in the community. So there are people who self-designate themselves as chronic pelvic pain people. They probably are better than the standard gynecologist in terms of evaluating them. And then there are the members of those organizations like the International Pelvic Pain Society who probably are a little bit more committed to this. And so, so not all gynecologists are created equal, just like we aren't as well.
We know what percentage, guys, maybe Neil and Mark and Meredith, but Neil and Mark have been working with the OBGYN guys. What percentage of patients who have, quote, chronic pelvic pain do you think are venous in origin, the pain?
Well, one way to answer that is 35 to 40% of the patients who they evaluate, they don't come up with a diagnosis.
Mm-hmm.
So it could be as high as that number. I don't know if it is, but it could be as high as that number.
And
Mark or Meredith, you have any thoughts on this?
I was going to say, I think that's the number that the literature generally throws out, is about 30% of chronic pelvic pain will have a venous component to it. It's a little bit hard to sort out whether that means that of women who present with chronic pelvic pain, 30% of them will have pelvic varicosities, which I think that's what it refers to. As to whether that's the primary or sole cause of their pelvic pain, I think is a little harder to get to, but that's the number that's out there, is about 30%.
I mean, this sounds a little bit to me like the wound center problem with venous disease. We know that patients with, present to a wound center, 30 to 40% of them, as some people think even more, or at least will have wounds that are venous in origin, and yet those wound centers don't recognize that that's a component and don't get an evaluation by a vein specialist and stuff. It sounds to me this may be the similar type of thing.
That is the problem, though. It's that there's a lot of cynicism about this. There's maybe it's not so clear cut. Radiologists, there they go again, trying to do another procedure to make money. But it's at least in the patients with the pelvic pain issue, it can be elusive to prove that that's what it is. Certainly causality still is questioned by even the chronic pelvic pain doctors, who recognize that at least a certain fraction of the patients that they're seeing have a pelvic venous etiology, but they still have some questions about it. The data still isn't strong, and then there are also some questions about our treatments. So they have some valid issues. It may date back to a little bit of the way they were taught. A lot of these, as Mark alluded to, a lot of these patients develop a lot of secondary problems. And sometimes the secondary problems, like depression and anxiety, become the dominant problem for the patient. And that's what you see when you see the patient. You don't see the pelvic varicosities. And so very quickly, this chronic pelvic pain that can't be explained by laparoscopy in the Trendelenburg position and ultrasound and cross-sectional imaging, maybe just be a problem with some sort of psychological problem that that may be necessary to address that way. So yeah, it is frustrating because we all see these patients who clearly have a dominant venous problem and symptoms that can't be explained by anything else, and they haven't gotten the attention. It seems so simple to us. It's just not something that's on their radar, and that's what needs to be done. I agree. We've been working on it at a society level and dealing with the experts. But I think the next stage will be to somehow, as part of that relationship, get ourselves in front of the audience of practicing gynecologists, not just self-invited to their grand rounds, which we've done and has been minimally productive, but to be invited by leaders in their community to come to their meeting and speak about what we have, and hear the criticism, but be prepared to defend it with data that hopefully will become more robust as time goes on.
So all right, so let's move a little, and I agree with you, Neil. I mean, I think we need to get to a higher level than, as we all said, just our local gynecologists or whatever. We need it to come from above, kind of from the top down, so they start to think about this. But Tony,
you could almost think, I'm sorry to interrupt, but even when we were uterine artery embolization was a new procedure, and trying to get the gynecologist to see that this was a non-operative solution for what always has been a disease that's been treated with hysterectomy. So I feel like pelvic venous disease is a very similar entity, and that here's a new way of thinking about a problem.
Meredith,
what do you
think is the pushback from the general practicing gynecologist regarding both,
So it's interesting. So with fibroids, the pushback was they didn't want to lose their cases, right? Because they were doing hysterectomy on all these women. I think with chronic pelvic pain, it's probably more cynicism, because these patients don't have surgical options. I mean, they can do a laparoscopy to look in and see what the problem is, or maybe put them on some medications, but there really are very few options that they have. I really think that it's just getting over that I don't understand. Show me that this works, show me that this is real. I think that's really the biggest obstacle in this case.
Right, and the problem is, and anybody else jump in, the problem is the literature is really not black and white regarding it's very muddy in terms of, do these people really get better or not? And I honestly think, as Mark kind of alluded to, that it gets lost in the mix. In other words, it's not this is the cause of all their pelvic pain problem. When someone has pelvic venous disease, there's multiple factors that, as they've had this chronic disease, that become confounding. So it's hard to get good data that says, okay, you do this procedure and this happens. So in a way, we almost cannot blame the OBGYN people for being somewhat cynical, because there is no great data that gives them a clear-cut answer that if you intervene, you're going to get 85% improvement.
And also, we can't convince the insurance companies because there's not real clear-cut data. So sometimes we get patients and then we can't even treat them because they're not going to get paid.
You can treat them, but maybe not get paid for it.
Okay.
Well, it gets back to even a more elementary level, and Mark will jump on this, I'm sure, but we don't even have a good set of diagnostic criteria for the disease. What are the criteria? How do you define it? And when you define it, how do you categorize it? And then how do you measure how patients do and improve in terms of outcomes after treatments? What's the natural history of this disease? All of these elements are, at this point, not homogeneous. There are a variety of different definitions that exist out there, a variety of different metrics by way they've been evaluated in terms of outcomes. that aren't necessarily so pure and so they don't give you, as Mark will describe, I'm sure, the signal that you're looking for. You may be looking at less clear output when you're trying to measure how patients are doing after treatment, because you don't ask the right questions or measure the right things. So there's still a lot of foundational things that need to be done to move this literature forward. And so, it is understandable that there's some questions about it, and certainly, as Mark said, I learned a lot from listening to the gynecologists about some of the things that could coexist with patients or in patients who have no other discernible imaging abnormality other than veins that could be responsible for pain that we don't typically think about nor typically evaluate. So, as has been described by a few people, I think these are the optimal patients to be evaluated in a really good multidisciplinary way by people who have experience on both ends. But there's no question that the pelvic venous component is not being considered by pelvic venous specialists nor the routine gynecology person in the community.
I was going to agree with Neil, but to get back to your point, Steve, it's not only that there may be more than one cause of pelvic pain in an individual patient, because I think everybody who knows who takes care of these patients, there may be more than one venous cause of pelvic varicosities in a given patient. A patient may have some primary ovarian vein reflux. They may have a little bit of left common iliac compression. They may have a little bit of left renal compression, and it's not uncommon to see a patient with more than one potential venous pathology. And I think deciding which of those is primary, can be difficult and contributes to the poor results, I think, in both because I think there's this historical, concept of pelvic congestion syndrome, which really doesn't mean much. And if you're going to treat every patient who has pelvic congestion syndrome with ovarian vein embolization, the results are going to be sort of what the literature says, which are less than perfect. But even if you understand that, and as Neil was saying, in patients who have more than one concurrent venous pathology, trying to sort out which one is primary can be difficult and contributes to the poor results, I think. And I think before we really, and I think we can partner with the pelvic pain doctors and the gynecologists to sort it out, but what really needs to be done is to build a whole framework to understand this problem with before we even get to the point of doing randomized trials. You have to have the framework first to understand it, then you have to have the outcome measures that are specific for it, and then you can start to study it, which is a long process.
So Mark, how do you even start something to look into it and do all the stuff we're talking about when you're limited in even the ability to offer treatment to get some of this data, right? And the industry has no interest, at least nobody so far, because the treatment options are pretty inexpensive from an industry perspective. So getting that support is out of the question. So I mean, how are you going to measure or look at improvement in symptoms if you can't even, you're limited in what you can do?
Well, I think as far as really robust data, that may be a few years off. But as far as a thorough evaluation of the data there is and presenting it for what it is the role of guidelines and advocacy. And really that hasn't really yet been done for pelvic venous disease. Is a really thorough look at the data with both its positives and its negatives, and saying based on what's out there now, these are the guidelines for how it should be treated, and then using advocacy to get that word out.
Because if you look at this is just like Steve mentioned earlier, very similar to your venous ulcer patient, where you have multifactorial pathology, you have data which is some of the data on some of the treatment options is questionable. And how do you measure, is it the reflux in the saphenous vein? Is it the perforator? Is it the compression? There's really multifactorial causes to really get a good answer. Just like with a venous ulcer patient, with a pelvic disorder patient.
Yeah, I mean, Mark, I tend to agree a little bit with Tony in that we're not even going to be able to get the data in the modern era if nobody is being paid to do the procedure, as Meredith already alluded to. It's very hard to get the kind of data that we want, and I mean, we all know how hard it is to get paid for these procedures.
We were getting paid for perforator, septs, ablations, and after a ton of patients being done and getting the information we needed, then we did some randomized studies, and even now, the data is not pure to tell you, if there's a ulcer, patient with a perforator under it, you're going to treat it and it's going to heal. There's no way.
Right.
I think ultimately we're going to have to do this through grants, and we're going to have to do true randomized trials in order to be able to prove it. And I think ultimately the way to do this is to really, there's obviously a heterogeneous population. There are different presentations and different physiologies when it comes to the venous disease, but we're going to have to take very discrete portions of that population and study them individually and do it very objectively, and not just case series where somebody presents the last 50 patients that they treated, but it has to be done the right way, where you're comparing it to some other treatment that would be considered the standard of care at that time, and then see the outcome. And that's the only way we're going to make this needle move.
Yeah, but who, in other words, and a lot of studies have been done going, in the past, basically industry funded studies, because obviously there was a semi self-interest and they wanted to seem like they're being altruistic for patient care. But as Tony points out, we don't have that in the pelvic vein world, in the pelvic venous insufficiency or pelvic pain world, where we can go to one or two people in industry and say, we'd like to have you fund some study. And if we're not going to get paid to do the procedures, then you're really narrowing yourself down to certain institutions where the physician gets paid whether the procedure is reimbursed or not. But for people who are working in a situation where if they don't get paid for something, they're not making any money and they're in fact losing money, it's going to be hard to get some of this data. And I see this as a huge impact. It's a catch-22. You want the data to show insurance that they should pay for it, but yet insurance will not pay for anything to get the data. So how do we break the cycle?
Right. What we need is good data, though. We don't just need data. We've had 15 years of case series on this, and they show a trend, but the quality of the data, the strength of the evidence is not enough to sway the payers nor the referring physicians who, or if we will, the gatekeepers of these patients, to send them to venous specialists.
Yeah, I'm not sure I entirely agree with that, because I do think that the first thing that's needed is a dispassionate look at the literature with true unbiased evidence-based guidelines as a starting point. And it's going to come out with a lot of low grade, low quality of evidence recommendations, but I do think that will move the needle a little bit when that happens, as long as it's done in a proper fashion. And I don't think you have to wait for randomized trials to start saying, as experts in the field who are knowledgeable of the literature, this is what we think the best treatment in 2018 is. This is the data that's lacking, and this is the data we need to accumulate to move the level of the recommendation up.
Yeah, I mean,
I suspect that may be a a little bit of we'll build it and they'll come kind of philosophy. I don't think I think it may make things go a little bit faster. I'm getting all these messages from somebody in my family trying to access something. Sorry. I don't think we unless we do those guidelines with thought leaders and influential members of communities that care for these patients. Am I still on?
yes.
Yeah.
Oh, okay. Yeah. No, Tony was so still there. I thought it was a frozen screen.
No.
But unless we get them to participate in developing those guidelines and get them to advocate for the positions in those guidelines, we may be building guidelines just like we built ulcer guidelines that the wound community just doesn't pay attention to.
Oh, that's absolutely true. And any guidelines for pelvic venous disorders have to include the gynecologist and the pelvic pain specialist. Absolutely.
Let me ask all of you, I'd like to discuss, okay, if you have a patient that you clearly feel the most likely cause of their problems or the most likely cause of the majority of their problems within the pelvis is pelvic venous disease. Do we have good enough procedures now to help them?
I thought you said that this was going to be easier to answer.
This is easier. So in other words, you make the diagnosis. It is clear that this patient's problem.
Diagnosis of what, Steve?
Of something between the diaphragm and the inguinal ligament as the cause of this patient's pelvic pain. Do we have good enough procedures
of venous origin?
Of venous origin. This is the ideal patient. They come to you. There is no question in your mind that 80% of their problem is due to some kind of problem of the veins between the diaphragm and the inguinal ligament. Do we have good enough procedures in the right patient that's going to give them a good result?
Depends on what that problem is between the diaphragm and the inguinal ligament.
Okay, so Mark.
Some they're good, for some they're not so good.
So give me where they're really good.
I think for a patient with a multiparous patient with primary ovarian vein reflux and classic symptoms of that, I think pelvic venous embolization is a good procedure, and if done right and done correctly. I think there's a lot of it that's not done right and done correctly.
No, let's assume it's done right, done correctly. In other words, as Tony already said, what I always say: the right doctor treating the right patient for the right reason.
Yeah.
You feel that if we embolize the ovarian vein,
in the right patient.
Yeah, in the right patient, of course.
But on the other hand, I think if you have a patient with even classic renal vein compression symptoms of flank pain and hematuria, I think there is the treatment for that is not optimal. No matter which way you go, whether it's surgical or endovascular, the treatments of that are not optimal. And I think a lot of that has to do with probably our misunderstanding on what the problem really is, and all of the procedures that we devised to treat it may not really even be addressing the problem.
Mm-hmm. No, I agree. I mean,
let us see, Meredith. What is the patient with pelvic venous disease that you like just say, oh my God, I just can't wait to take care of this patient. They're going to be so happy.
When they have, huge reflux in ovarian veins, I just get, like, this is going to be a slam dunk, and I know that they're going to feel better. When they have really tight iliac vein stenosis, and I know I'm going to put a stent in there and open it up, I know they're going to get relief. It's when it's, the vein is small and there's reflux and there's, you can see that there's a plexus of varicose veins in the pelvis, but, it's not amazing. And their patient, maybe their pain is lateralized to one side, but they have reflux on both sides, or they have generalized pain. And it isn't always obvious that what you're doing is going to fix their problem.
What patients do you see that you got to say, Jesus, I really got to be careful here. I'm not so sure I'm going to help these people. I want to kind of give some of our listeners and readers what do they think. So, Mark, you're joining us again.
Yeah.
I want to know what we were talking about you while you were gone. I want to know what is the one that you say, Jesus, I'm just not feeling this right now. This one I'm not quite sure about. What are those kind of patients, guys? And when I mean guys, Meredith, I don't mean just guys. I mean everybody on the call. I'm sorry, Meredith. What is the person that you say, you know what, I'm going to do this, but I'm not quite sure this is going to help?
Well, when their clinical presentation just isn't convincing, their pain is not necessarily at the end of the day, and they're just always in pain, or it just doesn't. Sometimes they just don't feel right. They're just it's just too vague, and I don't know. There's definitely patients when you're like, well, they have the abnormality, they have the symptoms. I'll talk to the patients and say, you could try, or they usually have tried everything. So, at a certain point, I said, we can try this, and if it works, great, and if it doesn't, then we have to think about the next thing. Or
all right, so we're getting to about an hour on this. Going forward, what impediments should we focus on overcoming first, second, and third? So we have the impediment to reimbursement, the impediment to the referring physicians, whether they're OBGYN, pain specialists, or whatever, and then the impediment to, well, I would put it this way, the impediment to making sure that the right people who understand pelvic venous disease take care of these patients, rather than just anybody who can put a coil down an ovarian vein or a stent in an iliac vein. So where should we put our efforts first? Is it educating the physicians who see these patients before us for some type of pelvic symptoms? Is it seeking out the patients, the appropriate patients to come? Or is it something that we should work upon educating those people who treat vein disease?
Reimbursement.
right.
Reimbursement. Meredith says reimbursement. Tony says reimbursement.
I say reimbursement.
Mark says reimbursement. And Neil?
No, I think ultimately reimbursement is going to be important if we want to be able to, for the access for the patients to be able to get the treatment. But I think we're going to have to do the hard work, whether it's starting with guidelines and moving to trials where we can prove that what we're doing works.
Yeah,
I think that's where the ultimate answers will come from.
Get reimbursement until you can prove that it works.
Exactly, but that's the catch-22. That if you don't get paid to do what you're doing, you're not going to do it and stuff.
Steve, I think it really keeps patients from getting the care they need.
I agree with you.
Get paid for it or not, it makes it so, and it's a very misogynistic sort of environment that I think there needs to be an advocate for these women who have these problems against the payers. Just and I don't know the best way to do that other than having patients themselves get involved.
Yeah.
But there's certainly lots of women who could be helped who aren't being helped.
Right. I think if we can get the gynecologists to support this, then a lot of this negativity with regard to these procedures will improve. When we got this whole interdisciplinary project started, I spoke to a recent president of the American College of Gynecology first. I went up to her and brought up the concept and said that we'd like to, begin to explore some of this stuff together as a group. And she said, well, many of us in the gynecologic community just don't believe in this. It's not a real entity. So it's not purely it's not like guys telling women that their problem doesn't exist. It's women gynecologists who also don't believe it. So ultimately, if we can get them to advocate for us to do this, then even if the data isn't so much stronger than it is now, I think we would get a little bit more traction with the reimbursement issue. Right now, they're against us as a community.
I've never done a peer-to-peer review with a female gynecologist for a pelvic congestion syndrome. It's usually a male medical director.
That may be because most of the medical directors are male and retired.
I'll tell you, when I've talked to female medical directors and explained what the patient's problem is, and the female medical directors are always like, "Oh my God, of course we have to fix that."
Yeah.
So.
Yeah. And also a female doctor helps too, I think.
Yeah.
The fact that you're talking to them.
Right. Yeah, exactly.
Yeah.
Well, when you look at, Neil, as far as showing this, that it works or not work, or, I mean, look at varicoceles in men.
Exactly. I was going to ask you to talk about this, Tony, because you've gone through this already, Tony, trying to get the reimbursement.
Yeah. I mean, why is it? Because you look at the data, and there's studies out there showing that it helps, and there's studies that it doesn't help. Yet,
yeah, the data may actually be stronger. The data may actually be stronger for embolization in women than maybe in men.
It is.
Exactly. That's Tony's point.
Right. But you can feel a varicocele, and you can, you can see it's there.
Right. And when you're a male medical director, you can imagine a varicocele, and you say, "Yeah, I'm going to do that." But when you're, when you're a male medical director and you can't see it and you can't feel it and you don't have pelvic pain, you kind of say, "What's the big deal?" And I do believe that is an issue.
I mean, I'll tell you right now, it's when I spoke to, I think it was Empire medical director. It was actually a nurse. It wasn't even a medical director. Her comment to me was, when they see the code for embolization, the CPT code, they automatically deny it. It doesn't matter what the hell the reason is for, which is pretty interesting. So it's almost like a red flag, that automatic denial.
Yeah. So these are obviously a significant amount of problems, but I do think the more we engage with the vein societies, plus, as you all have said, with the OBGYN people, that we can hopefully get some more reimbursement. What scares me, though, is, and I don't want it to get out of hand, if these things become reimbursed,
forget it.
There's more people that are going to just be throwing coils down ovarian veins for the wrong patient just because they have a dilated vein or something. Mm-hmm. And what's the literature then going to show? It's going to show that a lot of people don't get better because the wrong patient is being done. Mark?
Well,
Mr. Skepticism?
As we know from the saphenous veins, it doesn't even have to be a dilated vein to
exactly
coil down.
So it's, we need reimbursement so we can get data, but yet maybe it would be better if we could get data before reimbursement, and then who are the people that will be doing this? Who's going to be putting coils in? Who's going to be putting stents in? And
that's why I think either societies or, it's not the medical directors of these insurance companies that should be coming out, with the policy of reimbursement, because that's how the abuse starts.
Right. Exactly.
There needs to be strict criteria based on at least what we know, or the specialists that deal with this know, as far as indications for treatment.
I mean, Meredith, let me ask you this, and we're gonna end this in about 5 minutes. But Meredith, let me ask you this: a person who goes through an IR fellowship, and Neil, you too, is putting a coil in ovarian vein like a tough thing for them to do, or putting a stent in the iliac vein a hard thing for them to do? No, right? I mean, it's a rhetorical question, right? So this is going to be the problem. If you now get reimbursed to do something like that, and you're facile enough to minimize your complications, we're going to wind up with patients being treated for the wrong reasons, and then we're going to get data that's going to show that these people do not improve as much as we would think.
The explosion of iliac vein stenting. I mean, I think it's the same thing. So.
Exactly. I mean, all of us on this call call are not going to put a stent in an iliac vein or put a coil down an ovarian vein just because we can do it. We're going to do it because we believe in our hearts that we're going to help the patient. It seriously, it is a problem that needs to be solved, and I think it's a good step getting everybody together. Reimbursement, I think, is going to be hard going forward until we have some of these guidelines and everything that this multi-specialty group can hopefully come up with.
Mm-hmm.
Anything else? Anybody have anything else to say? All right. Everybody being silent, and being 10 o'clock on the East Coast, we are now going to sleep.
Good night.
Thank you all very much.
Thank you.
All right.
Bye-bye.